Just doing some quick introductions in the chat, name, organization, role, or anything else you may want to share. Feel free to share summer plans. All right, I think we'll get started. Hello, everyone. My name is Jackie Sizia. I am the Director of MCH Engagement at AUCD. We're so happy to have you here at the Autism Intervention Research Network on Physical Health, or ARP, at Autism CARES during our virtual meeting series in 2024. Today's event follows last week's theme for the Autism CARES meeting, which is strengthening the MCH workforce and system of care using innovative methods to measure and demonstrate program impact. We want to thank you for being here today as we showcase research from the AARP network. And before we get started, we're just going to share some housekeeping items. This meeting is being recorded and will be archived. Closed captioning is available, as well as ACL. Please keep your video and audio off until the plenary presentation. You may use the chat box at any time, as well as the Q&A function to ask your questions. Please share any feedback via survey at the end of the meeting. I'm excited to introduce you to Dr. Alice Kuo, Project Investigator for AARP, and Deborah Shelef, Co-Project Officer of AARP at the Health Resources and Services Administration. Alice, I'll let you take it away.
Hi, everyone. I'm Alice Kuo. I am Asian female with shoulder-length black hair wearing a dark top. I am Principal Investigator of the Autism Intervention Research Network on Physical Health, or ARP. We are an interdisciplinary, multi-center research network for scientific collaboration to increase the life expectancy and quality of life for autistic individuals, particularly for those in underserved and vulnerable populations. We want to express our gratitude to HRSA, and in particular, the Maternal and Child Health Bureau, or MCHB, for their continued support of our ARP research days at the annual CARES meeting since 2021. Now is a particularly exciting time to showcase the wonderful work being done by autism researchers because July is Disability Pride Month. I'm so proud that Lauren Brookman-Frazee is our speaker on her exciting work with mental health support in community settings. But first, a word from our project officer, Dr. Deborah Shelef.
Hi, good afternoon. My name is Debbie Quint-Shelef, and I'm a project officer within the Maternal and Child Health Bureau's Office of Epidemiology and Research. And I'm so happy to welcome you all today to this ARP Research Day focused on translating research to community impact. As many of you know, the translation and dissemination of research is of crucial importance to MCHB. Through our research investments, we aim to improve the health and well-being of children, adolescents, mothers, and families with a strong focus on autism and developmental disabilities. By building this evidence base and using new findings to drive change, translational research is crucial to improving outcomes and reducing disparities. ARP continues to grow its research portfolio with unique partnerships with organizations, self-advocates, and autistic researchers to ensure that findings are meaningful, relevant, and actionable. We look forward to hearing today's presentations and learning together how the translation of research findings can improve health outcomes in the autism community.
Wonderful. Well, thank you, Alice, for your vision and leadership and partnership that has led to such wonderful outcomes. And of course, Deborah, we appreciate your support and guidance for the ARP network. I am now happy to introduce Lauren Brookman-Frazee, who will be presenting on applying science to improve mental health services for autistic children. After the presentation, the floor will be open for Q&A, and questions are encouraged in either the Q&A box or the chat box. Thank you so much, Lauren. I'll let you take it away.
Thanks, Jackie. I'm so happy to be here. I'm just going to take a minute to share my screen. Are we good with the screen sharing? Terrific. Well, again, thank you so much for having me. I'm Lauren Brookman-Frazee. I'm a professor in the Department of Psychiatry at UC San Diego and the San Diego Lung Director. I'll be talking today about giving some examples of a line of research that has really taken advantage of community partnered implementation science approaches to improve community or publicly funded mental health services for autistic children. So we'll get going. I have a lot to cover. So I'll briefly start with an introduction to both the research and the community services context, highlight community identified needs related to autism and children's mental health services. And then I'll give kind of a broad overview of the iterative development of AIM-HIGH, and I'll tell you what that means in a minute, and how we've tested AIM-HIGH through effectiveness and implementation trials. And I'll wrap up by talking about next steps. So I want to get us grounded in that translational research context. So this kind of simple visual kind of highlights the different types of research that occur in the translational research pipeline, going from basic research to treatment or intervention development and efficacy studies to effectiveness and implementation studies. That is where I conduct my research, is and this research is conducted in routine care community-based services. So community services is a laboratory of the research that I conduct and my implementation science colleagues conduct. I'll highlight that this research aligns with the NIMH Strategic Plan Goal 4, so advancing mental health services to strengthen public health. So what is implementation science? When we talk about implementation science, it really refers to the scientific studies of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice, with the goal to improve the quality and effectiveness of health, or in my case, mental health services. So this visual on the right side really kind of illustrates that we're trying to bridge the gap between what is known and what's been developed in research to what we do in community services and community practice. So that's a very kind of brief definition of implementation science. As I mentioned, our research is conducted in the context of different community services. We know for autistic children that there may be multiple different service systems that are involved in providing some type of care or care coordination, education. The context of my research is in mental health services, children's mental health services. Typically, my research has been conducted in outpatient and school-based clinics or school-based services that are publicly funded. So either funded through Medicaid or funded through school district funds. And I could do a whole talk on the importance of mental health services for this population, but we know that mental health services are important in caring for the mental health needs of autistic children, and there are high rates of co-occurring mental health needs in this population, and behavioral needs. And so mental health plays an important role in broader care for autistic children and their families, I should highlight. So my research really started with community identified needs. And when I refer to the community, I refer to it broadly, often, community providers, consumers, families, individuals. What we heard a number of years ago is that there were concerns about the quality and the effectiveness of children's mental health services in caring for autistic children. Therapists told us that they were seeing higher numbers of autistic children in their practice or in their clinics or schools, and had some concerns about their ability to effectively service populations. So we started with a needs assessment, and we heard from therapists. There's a quote on the right side. We're probably somewhat all out of our scope of practice when we're dealing with these kids. We don't really have a lot of training. We're getting it as we go. We interviewed a lot of therapists and leaders, and they told us that they really had limited training in autism, developmental disabilities, and strategies, and felt ill-equipped with tools to effectively serve this population. Parents whose children had been receiving care said the same thing, and in many times they use the same words. There's a lack of tools. But the therapist, the quote on the slide from a caregiver highlights how much my child actually benefits is from mental health services is questionable. I see that some therapists are really just trying to figure out information and really don't know what to do to help. So I think what we found is that therapists were motivated to learn and to effectively serve autistic children, but they didn't have the tools to do so. So caregivers and therapists were saying the same thing to us as far as the needs. And so, so we responded to community identified needs by engaging in kind of an iterative and systematic process of developing and testing a clinical intervention and therapist training model with the goal to improve mental health services. And so we have partnered with community partners along the way. And I want to highlight who our partners have been. They've been caregivers and children. They've been therapists working in publicly funded clinics. They've been clinic leaders and supervisors, and also system leaders. So departments of mental health and school district leaders. And our process has really been framing community collaboration at the center of our work, and starting with always a needs assessment, gathering feedback, then responding to that feedback, refining what we do based on feedback, implementing and getting feedback again. And so this is kind of an iterative process that we've used repeatedly with the goal of improving mental health services. And so I'm going to briefly walk you through a number of studies. So there's 4 studies highlighted on this slide, and as to illustrate implementation science approaches and the outcomes of our work. So often at the beginning of the starting point for mental health or for implementation science is a needs assessment. So that's where we started, is before coming at solving this problem of therapists feeling that they don't have training and tools to serve autistic children in their practice. We wanted to assess, well, what specifically are the needs, and then develop a protocol and pilot test that. In this context, our primary community partners were mental health therapists, caregivers, and to some extent children. So what we did to respond to community identified needs is first a needs assessment. So we collected qualitative and quantitative data to assess what the clinical needs of children were and what were the training needs of therapists. And we gathered both therapist and caregiver perspectives. And we also were able to leverage some observational data on usual care psychotherapy that was not focused on autism, but really focused on usual care psychotherapy. So we took, in collaboration with our partners, we took the data that we learned from our mixed methods needs assessment, and then identify which evidence-based strategies could be used to meet these needs, and how do we package different intervention strategies and training strategies for this service context. And so we made a number of different decisions based on our needs assessment. So, and I should say that going into this, we initially thought that we could pull a protocol, an intervention and training protocol off the shelf and just use it. And what we found in our needs assessment process is there wasn't a protocol or training protocol, clinical protocol to just pull off the shelf and use it. So we ended up developing them. So we made a number of decisions together with our partners based on our needs assessment. The first one, really broadly, is that we wanted our clinical intervention to be designed for the population served and the structure of publicly funded mental health programs. And so, for example, that means weekly psychotherapy with variable degrees of or variability in how much caregivers were involved. We conducted this research in Southern California, where many of the caregivers, their primary language was Spanish. And so from the outset, we found it essential that all materials that would go to caregivers would be available both in English and Spanish. We found that the primary reason that autistic children, like non-autistic children, get to mental health services are for behaviors and behaviors that interfere with the child's functioning in their environments. And then we also decided to emphasize caregiver and child skill building as based on what we saw was needed to improve services. The other thing we did was develop a therapist training model. And that training model, we learned is that many therapists have limited autism training and limited behavioral training. Often there's a lecture in grad school, but really limited training. And what we found is sometimes there are some misinterpretations of children's behaviors. For example, considering behaviors as oppositional when they really weren't. And so one of the strategies we use is kind of taking an autism lens for behaviors and understanding what's the context that behaviors serve for a child and family. And so we really emphasize a process for understanding behaviors and then identifying and teaching skills to both parents and children in order to address those behaviors. We also heard a lot of therapists saying, we need help adapting the structure of psychotherapy for this population. We have a hard time engaging children, and they also needed help with treatment planning and goal development. We also included training videos in Spanish. Many of the therapists were delivering psychotherapy in Spanish, and so we wanted them to be able to, in part of their training, see some of the strategies being used in Spanish. So what is AIM-HI? AIM-HI stands for an individualized mental health intervention for children with autism. The clinical intervention, the way we describe the clinical intervention protocol is that it's a package of evidence-based strategies to develop individually identified caregiver and child skills to address interfering behaviors in the children. It's geared for children ages 5 to 13 who are receiving mental health services. So it's very focused on the mental health services context. There's no set number of sessions, but it typically takes about 5 to 6 months to complete, which is often the length of an episode of care in mental health services. As far as what the training model involves, it takes 6 months for therapists to initially learn AIM-HI. There's an applied introductory workshop where therapists learn AIM-HI as they are delivering it to an existing client or student. And so the introductory workshop is where we begin to help a therapist individualize the strategies for their target child. There's a structured consultation series that involves 12 sessions. They're very structured, include both 10 group sessions and 2 individual sessions. And then the therapist delivers AIM-HI to their existing case with guidance and performance feedback from a trainer. And we review videos and materials in order to support the therapist as they're learning AIM-HI. We find that the group process is really important. AIM-HI looks different for every child. And so the group process allows therapists to see how aim high looks different for other children. So what is the framework of aim high? So the first skill that we teach a parent is to identify patterns in the child's environment that elicit behaviors that are of concern for that parent, and what's the potential purpose of those behaviors. And so out of that process of tracking behaviors, the therapist and the parent identify what are the most common situations where behaviors occur, and what are the most common purposes or functions of those behaviors. Based on this information, we work with therapists to identify a set of child skills that can address common behavior problems. So it often is emotion regulation, coping, and to some extent daily living skills. Those are very common. And then complementary caregiver strategies, where we teach the parents to help modify the environment and to help facilitate the child learning new skills. And then we take a very active teaching approach to teaching both child and parent, where we include modeling, role play with practice and feedback. And across all of the aim high protocol, we really focus on teaching therapists to adapt to the psychotherapy process. So structuring sessions for engagement and skill building. And I think we highlight in aim high is that our goal is we take a strengths-based approach to working with families, both parents and children and broader families, and that the therapist's task is to help that family and that child to be successful. And so that helps drive us in determining how to set achievable goals, breaking down skills, and so forth, and increasing parent self-efficacy. We're often asked, is there curriculum? What do we teach in aim high? And it's really individualized to that child or that family. So there's no set curriculum, but it's based on the pattern of the child's behavior. But again, we often are teaching emotion regulation and daily living skills. So we developed a protocol, and the top part of this protocol steps, we call it treatment planning. That is the most structured part of the aim high protocol. And the reason that this is so structured is that therapists in our needs assessment told us they really needed help with treatment planning. They had a hard time identifying what are reasonable goals when they see a child for 4 to 5 minutes a week, and what are reasonable for the different characteristics of families. So that's the most structured part of the aim high protocol, but we spend most of the time in active teaching of the skills that are identified. We also, in response to therapists saying we need tools to adapt psychotherapy, we teach from day one, we teach therapists strategies for adapting the structure for skill building and engagement. So for simple strategies include using schedules, visual, written materials, engaging with a child's interests, incorporating parent priorities, and preparing children to teach them, preparing both children and parents to teach new skills. So unfortunately, I don't have time to get into all of the different strategies, but I want to get to have you have an overview of the process. So in our early work, we worked very, very closely with our partners to take the data that we learned from the needs assessment, develop the protocol, pilot test it. What we found is that it was feasible, therapists liked it, caregivers liked it, kids liked it. And then to conduct an effectiveness trial that was really focused on testing testing the outcomes for children and therapists when we train therapists in AIM. So a hybrid trial is a common type of trial in implementation science that includes collecting data on effectiveness and implementation outcomes. And so this trial was testing the effects of AIM-HI therapist training on the family's clinical outcomes and then collecting data on implementation process and outcomes. We enrolled mental health programs, either outpatient or school-based programs in Southern California. And then we randomized the program, not the people, but we randomized the program to either get initial training in AIM-HI or to get to deliver usual care and then get training in AIM-HI. So we were able to compare AIM-HI to usual care. And then from within those programs, there's 29 programs in Southern California that participated. We recruited family and therapist dyads from the participating programs. And then the therapists who were in the AIM-HI condition received initial and ongoing training as they delivered AIM-HI. And then those who are in the usual care condition delivered usual care. And primary outcomes was child behaviors, parent report of child behaviors, but we also included parent outcomes such as parent stress and parent self-efficacy. So this is our sample from the 29 programs. We had 172 therapists, 202 children receiving mental health services. What we see is that the therapists were primarily female, about a third Latinx, about a third bilingual, primarily master's level therapists. And the children were primarily male. A majority were Latinx. Their average age was 9, and but they ranged from ages 5 to 13. So what did we find when we trained therapists in AIM-HI? We found that we had an impact on therapist practice. So this graph shows observational ratings of the extent to which a therapist is using strategies that we teach them in AIM-HI and are considered evidence-based strategies. So what we found is that therapists, when they were trained in AIM-HI compared to usual care, that they did more teaching with and skill building with caregivers, that they did a lot more of engagement strategies with children. So incorporating their interests, sharing control. And then we saw increased structure in sessions, increased continuity across sessions. And overall, we saw a lot more skill building when we train people in AIM-HI compared to usual care. So what did we find related to clinical effectiveness? So we saw that the ECBI is the IBER Child Behavior Inventory. That was the parent report measure of behaviors that was used. So over 18 months, we saw significantly larger declines in the in behaviors in the AIM-HI group compared to usual care. And we controlled for autism characteristics and whether they were in a school or outpatient clinic. There was no child or family characteristics that moderated the effectiveness of AIM-HI training. Importantly, the observed therapist delivery of evidence-based intervention strategy helped explain the effects of training over 6 months. So in particular, the increases in session structure and the increases in continuity across sessions helped explain the effect of training therapists. We also found that caregivers reported significant decreases in strain, actually in both groups. So there's no differences there, but we saw reductions in strain. What we saw in the AIM-HI group is that there were greater increases in parent self-efficacy in the AIM-HI group, and that increases in self-efficacy mediated the training effects on child outcomes over the whole 18 months. And also the therapist delivery of evidence-based strategies mediated the effect on parent outcomes. So we had an impact on practice and the impact on practice, impact of child and family outcomes. So I mentioned in hybrid studies that we're looking both at clinical effectiveness, but then also implementation process. And so we did notice that there was variability in fidelity. Our fidelity data were not as high across the board. There's variability in there, and there's variability in how engaged therapists were in training. And based on some of our qualitative data, we found that leadership support was perceived to be very important in therapist success, as well as provider attitudes and motivation. When I was conducting this research, my colleague Autism Stamer was conducting a similar effectiveness trial for a different intervention in schools. And she actually found very similar facilitators or barriers of fidelity as far as leadership support and provider support. So we then combined our efforts to develop implementation strategies that were aimed to improve provider fidelity and training engagement. So that leads us to the last trial that we've completed, which is an implementation trial where we are focused on testing different implementation strategies to maximize the effectiveness of our training. And so, we really conducted two simultaneous or linked studies in which I was testing implementation strategies in the context of children's mental health, and Dr. Stamer was testing the same implementation strategies in the context of schools and classroom intervention. And our primary outcomes were successful provider training in our autism interventions and child improvements. So we tested two different implementation strategies. One of them was the Teams Leadership Institute, which includes kind of state-of-the-art implementation leadership strategies that to enhance the effectiveness of training in our two contexts. So that includes providing data to leaders about their climate for implementing evidence-based practices, and data on their leadership for implementing evidence-based practices in their context. And we did coaching about twice a month with leaders, and helped leaders support their providers when they were learning new practices for autism. The other strategy is a provider level strategy in which we were targeting provider level motivation by engaging them before we started them with training, being proactive and planning, anticipating challenges that a provider might have, and really with the goal of engaging and motivating providers to engage in the training process. So our methods are similar in that we enrolled programs in school districts over 4 cohorts, and then we randomized those programs in school districts, either with gold standard training, that provider enhanced training, the leadership enhanced training, or both. And we recruited the leaders and providers and families from those participating programs in districts. A subset of those received the team's leadership intervention, and a subset received the provider level enhancement. And we provided training to everybody. There's no usual care in this context. We provided training to everybody for approximately 6 months. So we had a total of 385 providers participate, and a total of 385 caregivers participate. And the leaders are not on this table, but we had leaders from each of our 65 programs or districts as well. Our primary outcome was whether the providers became certified in our intervention and their fidelity, and then our secondary outcomes were child behaviors. And what we found is that the Teams Leadership Institute was associated with higher provider fidelity and better child outcomes. So when a school district or a mental health program participated in the Teams Leadership Intervention, their therapists or teachers and their kids did better. We did not find the same effect of the provider level intervention where we focused on their motivation and engagement. the leadership intervention really was where we found most improvement. What we found is that the Teams Leadership Institute was associated with greater improvements in the climate of an organization for implementing new practices, and that the leaders provided greater support to therapists and to teachers for learning new interventions. What we found in our qualitative data and anecdotally was that we were focused on leaders in our Teams Leadership Intervention. What we found is that leaders wanted to bring in a broader team of individuals to support implementation. So they kind of did that on their own and felt that it was needed, particularly when we were doing training from a distance. And that led us to further refine our TLI to include a broader implementation team, not just the formal leaders in an intervention. So right now, we are conducting a new trial in which we are testing the effectiveness of TLI-2, which is our Teams Leadership Institute, to improve the delivery of autism evidence-based interventions and the quality of care. And what's unique about TLI-2 is it intentionally and proactively includes teams, including leaders, but other team members at each program or school district to support implementation of autism interventions. So that trial is happening underway, and we'll actually be comparing our data for the current trial to our previous trial where we just had the leadership focused TLI. And so another minute. So in summary, we use an implementation science approach to develop Aim High, and it was designed in response to community needs and the service context to improve mental health services. So part of our implementation science methods that we used was an iterative process with frequent stakeholder feedback and co-development, which then led to a feasible and effective intervention and training model that met the needs of the community providers and families. We've also seen in our data that better implementation is associated with better child outcomes, and that's our ultimate goal. And I should say better child and family outcomes. Another piece that I think is really important is that implementation is hard. The service system context, there's a lot of competing priorities, limited resources, and even when we design interventions for the services context, implementation is hard. What we found helpful is proactively engaging leaders does help maximize implementation efforts. And that the focus of our next research, or our current research actually, is on maximizing the functioning of implementation teams within school districts and organizations. So I think I'm right on time to pause and open it up for questions. So I'm going to stop sharing my screen so I can see all of you. But I think we have a few minutes for questions. I'm happy to answer those.
Thank you, Lauren. You did receive one question in the chat or in the Q&A section. It says, what were the perceptions of children and students in this intervention? How was social validity, acceptability, and harm reduction monitored as it relates to children and students? I will also put it in the chat.
So I think that one of the things that the trainers do, what we train our trainers to do is, so we're asking therapists when they learn Aim High to video record their sessions. And so the trainers give feedback to therapists based on their review of their sessions. So what our trainers are taught to do is to identify what aim high strategies that they see a therapist using. And then they also provide feedback on how does that child and that parent respond to their use of strategies. And so there's a pretty significant focus on how are the parent and the child responding. And sometimes it's parent only, sometimes it's child only, it kind of depends. And so I would say that that's pretty explicit and is the observed response, and actually the immediate response of a child. And then we give feedback when needed about how it's often about engaging children, following their lead, how to give them shared control in a session, and actually the same thing for parents as well. So I would say that probably one of the main strategies, the most immediate online strategy we use is the video review. We've in the past also gotten feedback from parents on the perceived effectiveness of the intervention and feedback on the intervention, and they have provided positive feedback. We haven't, given kind of the variability in children, we haven't done kind of surveys and interviews in that way for the children. But what we have done is that we have some of our child partners who helped us deliver, or helped us with our training materials. So when we teach about the autism lens to therapists, it's actually the kids, we have videos of the kids talking about their autism and how their behaviors may be perceived with what's really going on. And so the children, I think, play a really active role in that their voice is heard in the training. So they're the ones that are really teaching all of us about autism, and that's really powerful for the therapists as well. I think the first part of our training is kind of moving away from interpreting behaviors as oppositional, when there's so much more to it what's going on. So I think I went beyond the question, but those are the things that come up for me. And seeing this other question, how can the principles of implementation science be better integrated into current autism research? That's a great question. I think it is. So there's increased increased use of implementation science in autism, in actually a number of different contexts, in early intervention, in classrooms, and so forth. And I think that at the center of that is understanding the service context, understanding those who are being served, and partnering with them. And so those are some key strategies, but there's certainly, I think that's certainly been an increase in autism research that's included implementation science. There's an implementation science training institute, IRI, the Implementation Research Institute, and that started in 2010, I believe, and I think that there's been autism research that have participated in that over many years. So I think a lot of that is starting to happen. Great question.
Thank you so much, Lauren. And there's another question from Alice in the chat that says, hi, Lauren, this is such an amazing presentation on implementation science and effectiveness trials. It's great that you found that the TL1 maintained better fidelity to the model. How do you think the funding for TL1 could be sustained once this is launched in the community, more widespread and not a research project anymore?
Great question. So we're often thinking about sustainment from the beginning, both in our clinical interventions and our implementation strategies. What I think the option, and many organizations and school districts actually, and we haven't done this yet, we've been able to provide both our clinical interventions and our implementation strategies at no cost or no fee. There's cost of time, but there's no charge for it at this point. But what we see in a number of organizations and districts is that they actually invest in leadership training and leadership development, especially larger organizations do that. And what we're starting to do is to contribute to the evidence for specific leadership training. And I know that my colleagues who developed the intervention, ours is based on the Teams Leadership Institute. They contract with different agencies to provide that. They've definitely contracted with different agencies to provide that leadership training. So I think that it may be leveraging existing resources for both clinician and leadership training to be able to sustain some of these interventions. And it's on us as researchers to develop the infrastructure to be able to respond to that, and to be able to have our own workforce to be able to provide that leadership and clinical intervention training. Great question.
Are there any other questions for Lauren? Lauren, I have one question for you because I know that you are the also UC San Diego LEN director, and there's a couple LEN fellows on the line. What advice would you have for LEN fellows or any beginner researcher if they're interested in implementation science and learning more or being trained? You mentioned some options in your other answers, but what advice do you have for those beginner researchers?
So there are, fortunately, there's actually many different centers that provide some level of training and seminars and engagement and implementation science for folks. They may be, early career or more senior but new to implementation science. So we kind of see that kind of across the board. So at UC San Diego, we have a Dissemination Implementation Science Center, the DISC, and we offer those resources online. There's opportunities for consultation, there's webinars, and then we also have a children's mental health alacrity center through NIMH, and our website, and I'll put them in the chat in a minute, offers trainings and seminars, which there's opportunities to get on those, but we're not the only folks who are doing that. So if you're interested, I would encourage, exploring what types of seminars and trainings that are available. I think mixed methods is an important skills to learn in implementation science beyond community partnership, and there are a number of different opportunities for training in mixed methods.
Thank you so much, Lauren. Great. Well, that will wrap up our plenary presentation. Thank you again for such a wonderful presentation and for the great questions from the attendees. We will now start the poster presentations. I'm going to share my screen. In this next section, we're going to break out into 3 rooms. Each room will have one faculty facilitator who is also one of ARP's CREs, collaborating research entities, and 3 to 4 posters in each breakout section. Each presenter will have approximately 15 minutes to present and take questions. To respect everyone's time, we will have an AUCD staff member keep time and send chat reminders to the presenters. However, once the presenters are down to 1 minute on their time, an AUCD staff member will share their screen with an image of DC, which is a signal to the presenters and the attendees to wrap up so we can ensure that everyone gets their time. Once the presenters share their work, the floor will be open to pose any questions and comments to the presenters on their work. Please be ready to share out a few things that were discussed in each breakout room after this section, and you may self-select your desired breakout room. And this is just a slide showcasing the different breakout rooms. I want to thank the faculty facilitators, Lisa Schulman, Daniel Armstrong, and Calliope Holing for their time in facilitating today's poster presentations. So my colleague will now open the breakout rooms. If you have any tech needs or concerns into getting to your breakout room, please stay in the main room and someone will be there to assist you. Thank you, everyone.